Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello, good morning, everyone, and welcome to our Health Hour session this morning. It's good to see everyone, and we're grateful that we're all able to make it. We do have a really special session this morning on a very interesting topic. We'll be talking about preconception care, perinatal infections, sexual health, lots of discussions around sexual health, and we do have someone who is well versed in the area. We've got a consultant in the area, one of our own, who's been on the program a few times. She's part of our community, part of the family, and it's my pleasure today to introduce Dr. Vanessa Apea to take the stage and take us through this morning's session. Thank you.
Oh, thank you so much, Anna, and good morning to everyone. It's great to be here. As has been said, I'm going to be talking about a number of things, but related specifically in the whole theme of International Women's Day. And today it's going to be focused on an aspect of women's health. So bear with me. I'm just going to share my slides. Perfect. And I'm trusting that you can see that because I can't see anyone shaking their heads. Great. So, as I said, good morning. Lovely to be here. And what I'm going to talk about today is about a number of things, but really the title of Black maternal care and thinking that it requires a lifetime of care. And I'm, as has been said, I'm Vanessa Apea. I'm a consultant in sexual health and HIV, and I also do related research within women's health, particularly Black women's health at Queen Mary University, London. So we're going to talk about preconception, so how we prepare for pregnancy, even from childhood, perinatal infections and how they can harm yourself, the woman, the person carrying the fetus and the baby, and also sexual health, but really thinking about what does good sexual health look like. As ever, please feel free to put questions in the chat and we'll have the Q&A after. So, just to start off, I think I always like to highlight that it's when we're thinking about our lives and as we go through our lives, I think it's always really important to think about that life can be a lifetime of opportunities. So in terms of living, but also opportunities to intervene and give everyone the opportunity for good health. but also it's a lifetime of exposure to challenges and influences. And this all then accumulates risk in someone's life. So when we think about preconception and the time before someone gets pregnant, I always say that these are opportunities to really promote preconception health and reduce the risk that occurs in the early and reproductive lives of the woman. And that is whether it's for the first birth or it's for subsequent births as well. But what I've highlighted here is that these are really key opportunities that we can intervene to make someone have the best possible opportunity to have the most successful outcome of pregnancy that they can influence. So preconception health, so it's the health of women and men during their reproductive years, and so i.e. the years that when they can have a child. And so I always think of two aspects of this. So it's planning pregnancy. So it's enabling women and partners to choose if and when they want to start to grow their families. So it's that planning stage. But then it's also being fit for pregnancy as well, and recognizing that many of our pre-pregnancy health behaviors and risk factors are amenable to change. So meaning that there are opportunities before we get pregnant that we can try and be the most optimal in our health before pregnancy. And why does it matter? Why are we even talking about it today? And the aspect of maternal health and what it means in our communities has been so in our forefront of our minds, particularly over the last number of years, because we've felt it, we've known it. We can describe stories of where we may unfortunately have had negative experiences ourselves, or we know other people in our wider networks have had negative experiences of pregnancy and the outcomes of pregnancy. But we've had really stark data that women in our communities have an increased risk of poorer outcomes from pregnancy. So it's really clear that regardless, we need to work together as communities. The structures need to work and support us, but we need to understand what is driving these differences and why are we not having the same outcomes as our white counterparts. So when we talk about preconception health and that health before pregnancy, it matters because poor preconception health, it really limits a woman's choice, and it also impacts on the safety of the pregnancy and childbirth for both mothers and babies. And this, as we know, can have potential long-term consequences on child health. So what I may do, what I may have done in my 20s and 30s, as I've entered my 40s, and when I was getting pregnant, what I did in my 20s and 30s could have and did directly impact when I got pregnant in my late 30s. And then that also can impact on my children's health. And so you can see the key thing here is that generational impact that our health can have. So in an ideal world, what would we want? What would be the best optimal environment for when you're planning pregnancy and being fit for pregnancy? So we would have healthy behaviors, so a healthy diet, making sure that we had our folic acid supplements, regular physical activity, promoting emotional well-being. I mean, it's not something we're focusing about today, but being pregnant postnatally, it can be a time of great joy, but also a time of great stress as well. So having that emotional support and having that a good foundation of emotional well-being is so important. Things like cervical screening, sexual health checks and immunizations are all up to date. And I'm going to talk about that more later. And then our risk factors is in where we can intervene is that in an ideal world, we would not be smoking, we would have minimal alcohol, no substance misuse, our weight would be well managed, and we wouldn't have any significant long-term and physical mental health conditions. And other risk factors for pregnancy and poorer outcomes are previous pregnancy complications, genetic risks, maternal age. And something else here that I think is, something that's really I'm really passionate about is adverse childhood experiences. And that's something that we just cannot underestimate in how that determines mindset, physical attributes and energy. It can have a significant toll on physical and psychological well-being. And as I've said, with that generational impact as well, domestic abuse, and also migrant health factors as well. And wrapped up in all of that, in our ideal world, we would have the right relationships and support, education, housing, employment, financial stability, community safety, and this cohesiveness that is so important in our communities. But we know, unfortunately, that whilst we can dream and aspire to an ideal world and work towards it, we're not living in that now. And many people have different life experiences within the world that we're living now, and that can have significant impact on their opportunities for health, particularly in pregnancy. So I want to highlight about one area of thinking about preconception and obesity. And I often and about how to talk about it, because the key thing here that I think is really important is that I'm a firm believer that obesity is, it's a diagnosis, and it is, so we often, it's not about laying blame, but it's also thinking about recognizing the importance of helping each other to challenge obesity, to challenge those weight gains that we may be experiencing or someone in our life is experiencing, because it can have a longer term effect. So when we talk about preconception obesity, so, some of us have a genetic predisposition. So what we say is that within our genes, we will tend to be more likely to carry additional weight. And, many of us can relate and think in our families and extended families that this may be a possibility. And then also we have our lifestyle. Now, we're rushing about. It's all about the quick lifestyle. Often in terms of finances as well, poorer quality food is cheaper. And so the saturated fats are cheaper. What do we do? When I've got long hours and I want a quick fix, what do? I have a Whisper bar. It's natural. It's what many of us do. But it's recognizing how these food choices can impact us, particularly in this preconception state. And also at work, we've got the image of the lady sitting down there working hard at work, but it's quite sedentary, and will only perhaps have any exercise as they walk to maybe public transport or to their car. So there's a limited opportunity for exercise. But then what we see is that we're shaped by our genes, we are shaped by our lifestyle, but we're also shaped by our environment as well. And this whole understanding of it, it's not to kind of focus on all the wording here, but that's what we call epigenetics. So you may have heard of that. So it's our internal genetics. It's our what's happening in our wider world that can impact us in terms of housing, air exposure, pollution, etc., and then our lifestyle choices as well. And there is highlighted in smoking and drinking, and all of that can then impact the outcomes of pregnancy, and in that children that as a result of those that are obese can have then an inborn susceptibility, so more likely to have cardiovascular and metabolic problems like diabetes as well. So it's where we may be doing something to ourselves inadvertently, we are then shaping the risk and shaping the outcome of our children as well. And so it's, again, I've emphasized it, but it is this term of maternal lifestyle does underpin this intergenerational cycle of obesity and diabetes and other related disorders. And so, and when I'm working with women about this and talking to them, I always say it isn't never too late. So when we're, you know, whether it's just before you get pregnant, if it's while you're pregnant, reshaping that mindset, the diet that we have, incorporating exercise as far as this is safe, that can all make an effort and make a contribution, and a positive contribution to the outcomes of our children. And so don't feel that, you know, I didn't do it then, and, you know, I'm setting myself off on a bad foot and nothing can change that. No, absolutely not. At any time we make a decision that we, and it's not by no means easy, but we make a decision to say we are going to try and incorporate better eating habits, exercise, etc. The pre-pregnancy state is really important, but whilst the in utero, whilst the baby is in the uterus, that's a really important time as well. And that is, so that is really key. But these conversations are happening, and that's why I love coming to things like this, is because if you see there, that there's a typical start of maternal interventions is when we're pregnant. So it is about trying to shift that and thinking, what could we do? What could we have done previously? So I mentioned the Black experience in terms of maternal outcomes, and I, you know, it's not to reiterate it always and always, because I think for me, we need to be aware of it and then we need to do things to change it. But it's really recognizing that what we see in the outcomes, maternal outcomes, isn't unique and it isn't new. And it's exactly why we have health hours such as this today, to make sure that we are constantly making sure our communities are aware of what's affecting us, but then also can think about how they can intervene as well. And so, because when we're always hearing about health inequalities, but for me, I always emphasize that these are systematic and avoidable and unfair differences in our health between different groups of people. And it's a result of unequal distribution of social, environmental, economic conditions needed for health. So there are, and that then reduces our opportunity to have good health. Now, I wanted to highlight that, you know, on here we've got diabetes, cardiovascular disease, sexually transmitted infections that we may, and mental health concerns that we do see in higher rates amongst Black people, and for some of these, particularly amongst Black women. But when we are trying to understand, you know, what is driving these differences, and then thinking about how we can respond, I just wanted to highlight a picture that I always use when I'm talking, because I think it puts it really well. And you know, we don't need to, we all know racism, we all experience it day to day. And we all know that it's not just that individual racism, it's that wider institutional racism that can impact our health and opportunity. But I wanted to talk about how discrimination can influence your health as an individual, because sometimes it can be really hard living this life and then thinking, gosh, you know, what else, what am I in control of, and why do I have sometimes a physiological or biological response to what's happening around me, and is it something that is true? Is it am I dreaming it? Is it in reality? And what I would say is that, you know, you're not dreaming it. It is a reality, and there is clear data to show that discrimination, and everyday discrimination, is associated with biological changes within our body, whether that's coronary artery disease, blood pressure, cognitive impairments, or our brain function, sleep, but also, relevant to what I'm talking about today, lower birth weight as well. And so this is not to kind of just focus on racism and, you know, how that manifests, because, you know, many people will be thinking, how can I control that? And obviously not. But what I wanted to highlight is there are some things that we can do, and there are some things that we are not in entire control of. But what we need to try and do is that the things that we may have more control of, to make some changes in our lifestyle, really to give us that best chance, but not dismissing that all these changes in terms of discrimination, we call it the concept of weathering, you know, and I think it's a beautiful term because it's really visual. So our bodies get weathered by what we experience. And so it's balancing that against things that we can intervene on. So when we think about the preconception pathway, and I mentioned that, you know, there are a number of opportunities along our life that we can access care, or we can think about how it can influence our outcomes. And there's no question that having a better starting life and having more support in our family networks, whatever the shape of our family, but having that network around us is crucially important. School and further education is crucially important in terms of you know, just giving that opportunity for social mobility and gaining things, but also the education to be aware of your health and how to prioritize your health as well. Our friends, family, and community are crucially important. And then there are other aspects such as our sexual health, and our sexual health can definitely impact our outcomes within pregnancy. Cervical screening, just emphasizing this here, that for many women, in a recent survey, 11% of Black respondents, should I say, reported that they had forgotten or had not attended their cervical screening appointment. And that really is much higher than the national average of people that put off their appointment of 7%. So we're less likely to go for our screening, but this is something that can really optimize our health, because it then tells us whether we're at higher risk for cervical cancer or abnormal changes in our cervix, and something can be done about it. So again, it's an opportunity to be at a healthier point in our lives when we try to get pregnant. That general healthy adult lifestyle that I've mentioned, I think we can't underestimate the importance of relationships, as I've said, in our networks, but also our personal relationships with our partners that we may or may not choose to continue and have pregnancies with. And then also, you know, as we get to the point that we're more decided, folic acid is crucial. And so we've talked about some of the opportunities, and again, thinking about all these risks that happen across the life course, and then thinking about early interventions to manage these risks across the life course. So I've mentioned things about genetic risks. I've mentioned about adverse childhood experiences and domestic abuse. And the reason that it's important to highlight is that whether we experience it, whether we know someone in our network that has experienced it, it's important, I think, for us to recognize that that is something that can influence their longer term health and their future children's health. And at that point, they may not realize that. So supporting them to take up interventions to support them, you know, you'll be helping them, but you'll be also helping them and their children in the future. So all of these, some of these risks may not be relevant to you, but know that they are important in someone's life, but they are particularly important in someone's preconception care. So whether it directly affects you or whether you can see it in someone that you live with, your family, your network, do support them and speak to them and let them know about the importance of intervening on these things so that they can have better outcomes. So such as obesity, alcohol, smoking, teenage pregnancy, in the terms of supporting people that may have had a teenage pregnancy, or if you do see our younger population that may be starting to experience sex earlier than we may like, talk to them about the longer term impacts as well. substance misuse, migrant health. I think migrant health is something that is so important, and many of us on the line can relate to in the terms that being a migrant has so many implications, and being a migrant at different time points as well, because you may be a first generation immigrant, but you're settled in the UK, you know how to access things, you know how the way of the world works. But then also, you could be someone that's newly moved, or you can see someone newly moved to the UK. And the UK is not always the most friendly, and it's not saying that other parts of the world are far more friendly, no, but we're talking about the UK and England, is that navigating the system of the UK is not straightforward. And so knowing that you can access primary care, that you need to go to your GP when you're pregnant, you need to then make sure you see your midwife, etc., that may be lost to someone. So, and then that can then I often see women that have migrated over and then come to the sexual health clinic quite late in their pregnancy and have never seen anyone during their pregnancy. So it's a real opportunity to just share this learning, that it is crucially important to engage in health services as well. And just recognizing and emphasizing to people that I think in my work, I always think particularly our communities, don't know that there are lots of opportunities for support, and part of it is the system not letting us know, and that is a real problem. And then part of it is sometimes that we don't talk about what we're going through, and because we're not specifically asked about it, which we should be, we then don't get the right opportunities for support. And I think this is why initiatives such as the CATHIP initiative exists, because it's about all the organizations letting everyone know what is available. But I just wanted to highlight that there are so many opportunities for support for our prenatal preconception care. And I'm going to just talk about a story that I've talked about before, but I think it really puts it into context, and many of us may relate in people that we know in our lives, etc. And I do put disclaimers here, because in this story and in later on, just when talking about wider sexual health and perinatal infections, sometimes if you have been through it, it can be quite triggering. So just to give a warning for that. But this is a story of Michaela, who was first seen in a sexual health clinic age 17, and she was from the DRC, from Congo. And she left care and she was leaving care, the following year. And again, those in care and transitioning out of care are at a real risk in terms of vulnerability and not having that right support. And so often when we see girls leaving care or transitioning, they tend, I've often seen them having more difficulties in their pregnancy and managing afterwards, simply because they don't have that network of support. But in this case, Michaela, her mother was unknown, her father had passed away, and she was taken into care age 14 after her grandmother had developed Alzheimer's. And unfortunately, she was sexually assaulted at age 15. There was no penetration, but she had experienced that assault on her body. And she was a smoker. Her BMI was normal. We can talk about BMI later, not the best measure of weight, but it is used, but it was normal. But she was excelling academically and unsure what to do in her next steps educationally. And she was talking about her first sexual experience and requesting contraception and the injection. So already here we can see, in terms of her age, her adverse childhood events, and her mental health, just a number of factors that could have been influencing her, and as I know, were influencing her. But the reason that I highlight this is that it's when we see it in those around us, whether we've experienced it, it's important about trying to support early support and intervention. So she was seen at the sexual health clinic aged 20, and she was a few years later, and she was attending for recurrent thrush. And since then, she'd become a heavier smoker. She'd gained more weight, but she was with a partner and was studying and had some financial difficulties and was experiencing quite severe anxiety. And she'd missed a number of her injection appointments, and she'd so when I saw her, she'd had a positive pregnancy test, and it was unplanned. So here she had been a smoker, obesity, and worsening mental health. So she continued with her pregnancy, and unfortunately, the baby, I'm going to reverse that. Baby was well and being born, and so that's very, very fortunate, and she was delighted. But the baby had a low birth weight, and one of the things, unfortunately, Michaela then developed postnatal depression. And one of the things that we talked about when we were reviewing things and supporting her, I felt that there were many missed opportunities for supporting her and intervention. First of all, acknowledging all the trauma that she'd been in before, acknowledging what I said about weathering, about experiencing different levels of discrimination and how that impacts her, but then how we could have supported her mental well-being and building her resilience and giving her physical health advice. When I saw her at 17, when things were going okay, but she was at a specific point in her life, and I could have supported, and not just me, not putting the blame on me, but it's about reflecting about opportunities for intervention. But all was not lost, and we did give a lot of support for her when we saw her about 4 weeks after after delivery. And then when we saw her at 8 months later, things were much better. She was engaged in mental health services. She was had longer term contraception. But what was really key was that from learning from what she'd been through, we then had many conversations about how to plan for the future in pregnancy. And so, yes, the first pregnancy had its difficulties, but all is not lost. And it's about learning and moving forward from that, which we're doing. And hopefully she will go on to have more successful pregnancies. So when thinking about that preconception care, I just wanted to move on to perinatal infections. These are infections that include pregnancy-associated infections, fetal infection that can happen during labor and delivery, and then other types of infections that can happen quite soon after birth, in that 1 month after birth. And the key thing here is that what happens is that if the mother has an infection, that can pass on via the placenta, via the blood to the baby, or it can, if there's a ruptured membranes, if the sac that the baby is in ruptures early, that infection can pass to the baby. But also during delivery, if there is an infection and it hasn't been treated, that movement, if it is a vaginal birth, movement through the birth canal or through cesarean section, but mainly through the birth canal, maternal infection can be passed on that way. Maternal infection can also be passed on through breastfeeding as well for some infections, and with HIV, and I'll talk about that very briefly after. But the key thing about this is that to know that it can happen, and that it is an important cause of stillbirths and complications in the newborn. And why we felt it was important to talk about today is that many infections go unnoticed. So it really emphasizes that it's important to engage in prenatal care and perinatal care, so that when you go to your midwife, you're making sure that you're having all the right screening, you're having all the right vaccinations to prevent infection passing on to the fetus. And highlighting this here, there are a number of infections that I could talk about and that we do see. I am just going to talk about three very briefly, and just to make sure we've got time for discussion, but to highlight them. But this is a term that we use within medicine to just to remind us as well as physicians and clinicians to make sure that we are testing for these and considering them as well. Because the key thing about any infections in and around pregnancy is early recognition. So highlighting it early, and that's the key, that's the cornerstone of management. And also making sure that the mother and the fetus receive the right care and support that they need. But I am going to focus on syphilis, HIV, and herpes. So syphilis, first of all. So syphilis is a sexually transmitted infection, and it's caused by a bacteria, which is called Treponema pallidum. And I just put a picture there, it's just squirrely there. So, and all you need to know is that it's caused by a bacteria. The thing about syphilis is that it causes a wide range of symptoms that can be confused with many other illnesses as well. So it's not really clear cut. So you can see someone and or someone can be experiencing symptoms of syphilis, but unless they've gone for screening or unless it's on the radar of the doctor that they're seeing, then it can quite easily be missed. And so that is why within antenatal care, it is routinely screened for. And the other thing, which is, you know, for so many health conditions, is that some people may not have symptoms at all. And so we start off sometimes that it goes through different stages. So you can have a sore, it may then go into the bloodstream and cause a rash around the body. It then can affect our other organs, such as our heart, our brain, etc., over a number of years. But as you can imagine, those things can be caused by many other things. And so the important thing is to have that regular screening to make sure it's identified. And one of the reasons I wanted to highlight it is that over the past decade, we have been seeing annual increases in syphilis cases. And when you see general increase in the population, you then, by virtue, will see increase in syphilis infection in women of childbearing age. And then you can ultimately see increased cases of congenital syphilis. And syphilis, let me be very clear, is that we have treatment for it. So it is an infection that can be contained and eradicated, and we can give you treatment to clear the infection. So we shouldn't be seeing congenital syphilis in a world in which we have treatment for it. But unfortunately, we have been seeing an increased number of cases. And you know, between 2010 and 2017 in the UK, we had 21 cases. And sometimes that doesn't sound much, but it is. It's when I'm saying that we shouldn't be having any, and we're seeing 21 cases, that's 21 children that have been affected by an infection that they didn't need to have. And one of the things is that approximately 2/3 of infants with congenital syphilis do not have symptoms at birth and will show symptoms later. So testing is really important. Making sure engaging in antenatal care is important, but also it's important for the medical community, the clinical community, to have a high risk, high suspicion for any developmental changes that may happen in a child to consider syphilis. Herpes. So herpes is another sexually transmitted infection, and this is caused by herpes simplex virus. And we have two types of virus, type 1 and type 2. And we used to think of type 1 that was mainly in the mouth and passed on by kissing. And then type 2 was mainly in the genital areas, passed on by skin to skin contact. Now, but however, we see type 1 in the mouth and type 2 in the mouth and type 1 in the genital area. So that really becomes much of a muchness. But genital herpes is a really common sexually transmitted infection. But unfortunately, like many infections, there's a lot of stigma around it. So people don't like to talk about it and often are shrouded in a lot of shame about it. But it is incredibly common. And I often say that we see cold sores on people's mouths really commonly. And we see there is the same frequency of genital herpes, but obviously you can't see it as someone's going around. So that is really important to know. But genital herpes can influence pregnancy. And so it's really important that if someone has herpes, or if they've had herpes and they get pregnant, I encourage women to please tell your midwife, please tell your doctor, because sometimes what I find is that someone's so nervous and ashamed about it, they don't share that. And it's important because if we don't manage it, it's something that can be passed on to baby. Now, if someone has, let me step back, the severity of the symptoms and the impact on the pregnancy really varies, and it depends whether someone has had herpes before pregnancy and also how far along they are in their pregnancy. So if someone has had herpes before pregnancy, generally they will develop antibodies, and if it's before around 6 weeks, those antibodies will then pass on to the fetus, so that gives the fetus increased protection. So and so there will be a passage of antibodies to the fetus. And with that, however, if someone develops herpes in pregnancy later on, then there is a risk that if it's less than 6 weeks before delivery, then there's a risk that the baby has not had time to get any antibodies from the mother, and there's a risk that from the placenta and through delivery that the baby can acquire herpes. So what we say is that what's important is that if someone has herpes and they have an episode in pregnancy, that they must be treated. So and the treatment of acyclovir is safe it's given off license, but it's deemed safe in pregnancy. And so we give women treatment when they have an episode in their first and second trimester. But all women that have had herpes or have developed herpes within pregnancy, we will give them preventative treatment. So we will tell them to take an antiviral, acyclovir, from their 36th week of pregnancy to just give them added protection and reduce the risk of passing on herpes to the baby. So there is things that can be done, but generally, like many things, if we don't know, we can't intervene. I'm going to be very quick here because I'm really mindful of time, but neonatal herpes, so it is rare, but it can have a serious impact, and it happens in 1 to 2 out of every 100,000 newborn babies, and it can affect the skin, it can affect the brain and the spinal cord, and then it can affect many organs. And some of the signs may be the baby may be lethargic or irritable or poor feeding, high temperature, a rash or sores on the skin. But what's important here is that for those of us that have had a child or experienced it in our network, we know that these symptoms can be quite, that can be any other infection as well. So again, it's about always communicating with those that are looking after you so they know if it's something of relevance. And then I just wanted to pick up on HIV and a really clear message here. So HIV is human immunodeficiency virus. So it's a virus that affects the immune system, and it causes people that do have the virus to be at risk of everyday infections and rare infections as well. So it affects the immune system. But where we are now with HIV is completely different to where we were 20 years ago. We have fantastic treatment available. And the key thing is, because we've got really good treatment, we have also learned this issue of undetectable is untransmittable. U equals U. We know that someone living with HIV and that is on effective treatment and which controls the level of virus to a level of undetectable, they cannot pass the virus on to their partner, their sexual partner. And in that same way, if someone is living with HIV and they are on treatment, they will not pass the virus on to if they're pregnant, they will not pass it on to their baby. That is crucial. And I really wanted to emphasize that, because if someone is living with HIV, whether they've communicated that or not to anyone in their health circle, in their family circle, people often sit there and think, I can never have a child, I'm going to pass it on to my children. That is not the case. There is treatment out there to prevent that. But the problem is that because of the stigma and shame, many people don't go and test for HIV. They don't go and test for infections. So therefore, that's when the infections get passed on to the fetus, because we haven't been able to intervene. And top tips for when mitigating and dealing with perinatal infections: encourage yourself, encourage those around you to attend antenatal appointments, partake in the infection screening, sexually transmitted infection screening, discuss vaccinations, discuss any travel that you may be doing, maintain good hygiene, the simple things of hand washing, etc. And then the other things that are well communicated about making sure you've got eating well cooked meat if you do eat meat, avoiding unpasteurized milks and foods, and not touching cat litter and contaminated soil. And as I say, in this world of the pandemic that we're living in, just been having that heightened vigilance of, hands, face, space in this case. I want to give us time for questions. And I think what I wanted to talk about for sexual health just really is that I've mentioned the infections that can be relevant in our preconception and perinatal care. So when we talk about sexual health, we often only think about infections. And the World Health Organization talks about sexual health as being a state of physical, emotional, mental, and social well-being in relation to sexuality. And it is not just an absence of disease or dysfunction. It's about having pleasurable and safe sexual experiences, free of coercion, so free of being forced, free of discrimination, and free of violence, so that we can have a positive and respectful approach to sexuality and sexual relationships. And I think that is what good sexual health is. And it's not just about testing. Testing is really, really important. And if we have poor sexual health in its entirety, it results in unplanned pregnancies and termination of pregnancies, psychological consequences, transmission of infections, cervical and other genital cancers, pelvic inflammatory disease that can cause ectopic pregnancies and infertility. And as we've been talking about today, poorer maternity outcomes for mother and baby. But it's everything in its entirety when it comes to sexual health. So it's just about recognizing that we have to have a positive approach to going to the sexual health clinic, testing, but it's also about being in spaces that we can have safe sexual relationships as well. And I'm going to end on, I have to say in my sphere that many of us will go to a sexual health screen when we have discomfort, when we are in pain, when we have symptoms. But I really encourage this concept of a yearly sexual health MOT to encourage that significantly. Great. And I'm going to stop there. And I'm many apologies because I can hear one of my children crying. So apologies, but I'm going to stop there for questions.
Thank you so much, Vanessa. That was a multiple whammy. You did that beautifully. I could tell you had so much to give us, and you've done your best to give us as much information as possible. So very useful bits on the preconception care, the importance of us realizing, sorry, I just put my video on because I just realized it isn't on. As realizing that poor preconception health or preconception care can have an impact on the pregnancy, an impact on the child, an impact on the child's experiences, and even beyond into generations. So that's quite important that we see it not just as that big, but actually can have an impact through generations. You talked about obesity as well. You highlighted the fact that it's never too late to make positive changes, and how various aspects can impact our preconception care. And then obviously you've talked us through the perinatal infections as well. So thanks for all of that. Right, so we want to take some questions. Do feel free to put your questions in the chat box. Some people have been putting questions as we've gone along. We do have a few questions to start off with. So a couple of questions for you to begin with. Someone is asking, are these STIs, these sexually transmitted infections, are they more common in Black women? Are they more common in Black women? And also someone asked, can HIV be passed on to their children? I know you kind of answered that, but if you can just touch on that as well. Thank you.
Perfect. Thank you so much. Thank you, Diana. So, with sexually transmitted infections, yes, we do see. So the top 5 that we see in terms of chlamydia, gonorrhea, syphilis, trichomonas, vaginalis, and genital warts. Did I say I'm going on to 6 now? Apologies. And herpes. A full selection there. When we do look at the numbers, we see increased numbers within Black and minority ethnic communities, and for certain infections, we do see it particularly increased in Black women. And one of the key ones is trichomonas, and I didn't talk about that because there is so much to talk about in this time. But trichomonas is a sexually transmitted infection that can cause a thin grey discharge, and can be, it's not about the pain, it's about the presence of the discharge and feeling uncomfortable, etc. Or we may not have any symptoms. But when we look at Black women, we see an increased rate of 8 times more likely to have this infection in Black women than white women. So there are definite infections that we see more in Black women and in Black communities as well.
Right. Is there any particular reason for that? Just on that point, is there any particular reason, why we're more predisposed to these?
So when it comes to sexual health, and like I was saying, it's multi-layered. So it is about one thing about testing. So, and the stigma about going to a sexual health screen and actually being active about that, because if you don't test, you don't know. So then you will pass it on to your partners and their partners as well, because, you know, sex is all networked. So that's really important. It's also in terms of people talk about sexual behavior and, you know, the use of or not using condoms. And that is directly relevant, but I bring it back about to use a condom in relationships. The man, or talking about male condoms, the man has to want to use the condom, because you can't force him to use a condom, and that requires a certain dynamic in your relationship. So if you are in a relationship that there's a differential in power, any abuse happening, you know, having a condom tick is not straightforward, and that is definitely relevant as well. Also, some of the things in terms of other infections, such as which aren't sexually transmitted but are vaginal infections, are things like bacterial vaginosis, and we see that more in particularly Black women. And one of the things that's really relevant there is that I definitely feel there is a cultural element to it because of our vulval care. You know, I'm always really candid about it. I always say when I got married, I was on the dance floor and my aunt whispered in my ear, you know, make sure you're clean down there, make sure you've used Dettol and all these other fragrance there to smell nice there, you know, because many of us, and I'm being facetious, but many of us have grown up with that encouragement about vulval care requires a lot of soap and nice smelling things in that area. But unfortunately, that can cause more discharge and more symptoms as well. Yeah.
Thank you. Thanks for clarifying that. And that's quite funny about what you said. So the next question is, can HIV be passed to children? And also in relation to HIV, is HIV treatment free in the UK, even if you're not registered with a GP? So if someone hasn't got a GP or they're not registered, can they still access HIV treatment, please?
Great. So I'll start with that because that's really important. So yes, if you are living with HIV or you are diagnosed, within a sexual health service, etc., you can access HIV care and treatment, and you do not need to be registered with a GP. It is free. It is free at the point of access, and so that should not limit you at all. And so I have a number of patients that do not have a GP or have not discussed it with their GP. I want to highlight that I and many doctors in HIV, we do encourage letting your GP know. So don't feel as if we're pressuring you for any reason that, you need to get on a register because you're going to have to pay. No, that's not the reason. It's just because to give you the best care, everyone involved in your care, it's great if everyone knows what they're managing. So that communication is important, but no, you don't pay for it and it's free. And again, with children, if someone is living with HIV, acquires HIV in pregnancy, and we are able to give them antiretroviral treatment, so treatment to deal with the HIV and bring the level of the virus down significantly, they will then not pass the HIV on to the baby. The difficulty is if someone does not let their doctor know and they do not allow screening, or they acquire HIV late in pregnancy and they haven't gone for regular testing, then that is when there is a possibility because they're not on treatment. But treatment prevents transmission.
Great news. Right. So next question for you is about herpes. Can people get herpes again? So someone wants you to sort of just clarify a bit more about herpes. They say, can you explain about herpes again? And whether once it has been contracted, it can be treated for good.
Great. Okay.
I'm supposing they want to know whether you can get it again. And also asking about if people are planning for pregnancy, could that impact it, which you've touched on?
Yeah.
Is getting genital herpes related to stress as well?
Great. Okay. No, that's perfect. And it's always great to have these questions because it adds all the depth which you can't cover with everything. So herpes in pregnancy. And herpes overall. So it's, as I said, it's caused by a virus called herpes simplex virus. And when we manage herpes, because it is a virus, it's not like a bacteria. So when I mentioned about syphilis, which is a bacteria, and like chlamydia, you can take treatment and then you can clear the infection. And so if you then test again and then you have chlamydia again, that is not because most times it's not because it didn't clear, it's because you've been reinfected as well. So you've been re-exposed to it. With herpes, because it is a virus, it's not something that we give you treatment and we can say that you will never have it again. And it's also not something that we can say that you will definitely not pass it on to a partner. And that is really important. Now, at the same time that I say that, people become so upset and stigmatized by that because they're like, I've got something that I can't get rid of, and I'm going to pass it on to my partners, etc. But there are things that we can do to support. So I mentioned the antiviral treatment. So that antiviral treatment, what it does is that it reduces the level of the virus. So then it reduces you having the symptoms, which can be blisters, a burning sensation. That can the treatment can reduce that, but also the treatment can also reduce the risk of you passing the virus on. So because of that, as I said, if you develop an episode of herpes in pregnancy, you let us know, we give you treatment, and that reduces the risk of you passing it on to the fetus, and it also gives you comfort as well in a time of pregnancy when it can be quite stressful, etc. And then it also we give it routinely to women at the end of nearing the end of their pregnancy to also, again, definitely reduce the risk during delivery. Now, if someone has had herpes pre-pregnancy, the data does not show that if you've had herpes that you're more likely to have a stillbirth or poorer outcomes from pregnancy. So that isn't the case. What we do know is that we need to reduce the risk of you having symptoms during delivery in the later part of the pregnancy.
Okay.
There were other bits to the question, but I'm not sure if I've answered
The stress
yeah.
bit.
Can herpes be brought on by stress? Yeah. So so definitely, I believe so. So one of the things I always think of an example is that you often see in life, you know, though in yourself, family, at work, when someone's stressed, run down, you will often see many people will have a cold sore on their mouth. And, you know, it's not for anything that's happened recently. It's just that something has gone on and they're stressed and it's flared up there. Again, that can happen in the genital area, but we don't see it, but it is very common. So stress is a driver of that. And so I often say that, you know, it's hard to say how do you like remove stress from your life, but speaking to someone when you have herpes and speaking about the options is really important, because otherwise what happens is that you're stressed, you get an episode, and then it gets in a vicious cycle because you haven't sought any support for yourself. So that's really important. Yeah.
Try as much as possible to avoid stress. That's if we can, to help ourselves. Right. So the next one is, how can we encourage women and men within our communities who have undiagnosed HIV to get tested? So how can we encourage people to sort of come forward for testing? And also, why is it that we appear to have more Africans contract HIV? What is being done to reach our men? So I think it's along the same theme of how do we encourage people? Why are we sort of more prevalent? Why is it more prevalent amongst us? Thank you.
So no, thank you. So for me, everything that overrides, underpins is stigma. So there is so much stigma related to sexual health. Anything related to sex, there's stigma. But HIV particularly, because of the campaigns that have happened before, because of the visual representation of HIV and AIDS, everyone puts, many people, should I say, aligns HIV to AIDS to death. And that stigma stops people going for a test, discussing it, encouraging people around them, and feeling confident to engage as well. And so I think that what we need to do is more things like this, having the conversation and saying and recognizing, and please, all of you here, you know, sharing it, that there is no shame with living with HIV, that someone living with HIV can have a long and fulfilling life. And the life expectancy for someone living with HIV and on treatment is the same as someone not living with HIV. So, but what happens, unfortunately, in our communities is that we do see the worst of it because we are diagnosed late. And like anything, like any of the perinatal infections that I talked about, you know, even obesity, if you intervene early, you can have better outcomes, but the later you intervene, the more negative outcomes that happen. So I think we need to get out there more. We need to speak to each other more, but I do think more resources need to be put into accessing our communities, but in collaboration with us. So, you know, I would love to have more people within our community get involved in initiatives, so that, because that's the only way it can move forward. Yeah.
And it's interesting you say that. Actually, if you do have HIV and you are on effective treatment and you're sort of followed up properly, your life expectancy is actually comparable to someone without it. I think that's important for us to take home, that it's important that people present early, get the treatment early, get it under control, and therefore you would improve your life expectancy. So that's good to know. Someone else is asking, Vanessa. It's a bit of a long one, but I think we'll get to the crux of it. How do we break this cycle of increasing inevitable risk to minority groups. So obviously you talked about Michaela's situation, and we see a lot of those around us. And she's saying, how do we break this cycle of the increasing inevitable risk? You know, most of the time we focus on racism, but the real risks are there, and we're lucky to be educated here, but probably not everyone is. How can we break these risks really practically?
No, I mean, that's a fantastic question. I think that so over the last 2 years, I've never said health inequalities more than I've said it in these last 2 years. But, you know, Diana, you know that this is things that we've been talking about for years. It's nothing new to us, but it's just that probably we just had a platform to talk about it. And it seems that someone listens and then they go into that. So for me, now we're aware, we're living it, but now other people are aware. And we are in a situation that for many of these facts, they can't get away from. I think we have to be relentless in talking about our needs, speaking up. When you have a negative experience somewhere, don't sit down. You know, last week I saw someone being spoken to so rudely in the hospital, and I went in and I got involved, etc. But the lady was walking away. Who experienced it was walking away in tears, and was, you know, I said to her, it is awful, but what I did is that I took her to PALS to write it out and then to make a complaint, because I said that, you know, most things in this world and most things in our life here, it's made for the majority, and as the minority we're trying to fit into it, and there are some things that we can fit into easier. But for many things, certain revisions, refinements need to be made to make us feel welcome and at the core of it and included. But that can only be done if there is will from structures, but then whether we tell people what they should be doing. And it can be tiring and frustrating, but I think that we need to keep pushing, and we need to keep asking and demanding, and we need to do it in a group so that when one person gets tired, someone else takes on the mantle, and vice versa. But we need to keep speaking, because otherwise it's easy for our voices to be ignored and not to be heard. Yeah,
really true. Thank you. So we keep trying. We're not going to give up. We keep going. That's the benefit of some of these programs. Now, what is good vaginal care, Vanessa? So you talked about us not using soaps and all the nice fragrances. What would you suggest is the best and best way to care for our vaginal and vulval areas, please?
No, definitely. And as whenever you do these things live and a child starts screaming, it kind of rushed me to the end. So apologies. But so water. Within vaginas, you think about it, there's a balance of good and bad bacteria there, and our vaginas actually cleans itself, so it is able to maintain balance. But then when we use soaps and bubble baths and things like that, that unsettles the balance, and we get more bad bacteria, which can cause the smell and the discharge. So water alone is the best thing to do. It's about doing it regularly, but water alone. Douching, I'm cautious of. So often douching is when people can take the shower head and direct it at their vagina, but then will use their fingers to try and go in and clean. And I don't advise that. I also say that, being very honest, because we have been brought up to be using products, etc., there are things that are non-fragranced and do not have the molecules in that can cause discharge, and things like epiderm. So that's things like that which are neutral, like aqueous cream on your vagina to keep the area moist, and then you can use that as a soap substitute to wash the area as well. So that's something else that can be used. So good vulval care for me is avoiding soaps, bubble baths, Dettol, etc., using water regularly, and using things like soap and using things like aqueous cream and epiderm as a soap substitute or moisturizer. Yeah.
Thank you. Thank you. Sorry to bombard you. We do have a lot of questions. It
No,
just
no,
tells
no,
you
no, it's fine. It's great.
how great and excellent this presentation has been. So I'll just
That's
fire
great.
through a few. So I'll give you a couple, then we'll come back. So why are Black women more likely to miscarry? So that's the first one. And then the second one is, are there specific initiatives to destigmatize HIV testing? So why are we more likely to miscarry? And then initiatives to destigmatize HIV testing, please.
Great. So I think firstly with the maternal outcomes and the miscarrying is that and relates to everything that I've said, is that as a woman, we don't sit in isolation. So we are determined by our genetics, etc., but we are determined by the life and the social environment that we are in and what we have access to. So it is multi-layered, not a cop-out answer. It is multi-layered. So it is access to healthcare, whether we access it or not, whether we have a good experience there. So then, because that may stop us engaging, then that stops us being open about what's going on in our life, because you only receive the best care if those that are looking after you understand who you are and what's happening. So if you don't feel safe to share that, or you're not given a chance to share that, that can impact your care as well, and what you need. So that is, but then, you know, housing, food, socioeconomic status and poverty, not having the right foods, not having the right housing, the stress of life, etc. All of those can feed into you being more at risk of infection, more at risk of carrying more weight and obesity, more at risk of behavior such as smoking and alcohol. You know, those things determine the factors that influence pregnancy and things like miscarriage and stillbirth. So there are so many initiatives that are being developed at the moment to think about at all those different levels, all those opportunities that I talked about. How do we intervene so that we can give someone the best chance? So all those steps I mentioned in the preconception journey, all can have a potential influence on the risk of miscarriage. And you said with HIV,
are there special initiatives to destigmatize testing?
So there are a number of initiatives, but you know what is beautiful, like sessions like this, because you know, gathering so many of our communities at one time each week is no mean feat. And I often say, if those of us here do not know about the initiatives, then we're not doing it well enough. Because what should happen is that everyone on the line should know about it. But there are a number of different local initiatives happening, testing in outside sexual health clinics, different magazines, blogs, podcasts, etc. But, you know, number one, anyone's got ideas of how to do it better, please feel free to email me, email CAHN, email CATHIP, because so we can share it and cascade it, because things are happening on the ground, but I don't think we know enough and we have enough information, and we need to do more, quite frankly. Yeah.
Thank you. And do feel free to email CAHN for further information on what's happening locally. What is your advice for women who want to delay pregnancy due to career goals and might be thinking of freezing their eggs? And what is the success rate of egg freezing for Black women?
Okay. Again, always great questions here. And something that I just talking about to friends just very recently. So I think, first of all, it's important to know that there is a possibility of freezing eggs, and for people to recognize that. What I would say is that, first of all, is finding where you want to go and freeze your eggs, where is available in your area, or if you're going to go out of your area to find it, but to do your research online. And so there are a number of websites, and I can't think of them all right here, but I'm happy to share, and I can get that sent to you if you want to email me directly, because there are a number of good websites that talk about the different places, but also people's experiences there as well. And also I do know that there is an online network of Black women in that same point in their lives, and they're really good at sharing their experiences and where they had, where they found a center that was really supportive. So I would say research, and when you do find people that have experienced it, talk to them, because we often make these decisions by ourselves and we keep quiet about it, but keep the conversation going and speak to people. So the success rate of freezing is, so we do see in some of the, I'm holding my head because I'm trying to remember some of the statistics. So we do see for some of the fertility outcomes from fertility treatment are slightly lower in Black women, but it's not, it's for a number of reasons. And sometimes it's generally the timing that people will go for it and etc. So what I will do, before I'm going to give you any information that isn't refined, because I think it's a really important question, I will get the facts and I will share it to you separately. I'm really happy to do that.
Super, thank you. And that information can be passed on as well if you want to. Now, because of time, I'll try and just combine 2 or 3, and then what we might say is that people can send the rest of the questions to the CAHN email for us to deal with. So the first one is, when requesting PrEP, when do they question whether a partner is an African or not? So our Caucasian partners less likely to pass on HIV. So when requesting PrEP, I'm supposing they're talking about pre-exposure.
Yeah.
So that is number 1. And then number 2 is, what happens if the male partner passes on herpes, but the other one refuses to accept? So I think something along the lines of, basically, someone is willing to accept that they've got it, the other person doesn't want to get treatment. What happens, or what can you do?
Okay.
I'll leave those 2 for you for now.
Yeah, no, great question. So PrEP is pre-exposure prophylaxis. So it's a tablet that you can take before sex, and it can protect you from getting HIV. So if you are having sex with someone that is living with HIV, or you're with someone that may be at higher risk of having HIV, you can take PrEP to stop you getting it. Now, when you look at the numbers of the new infections of HIV, there are certain groups that are more likely to acquire HIV. It can be men who have sex with men. It can be people of Black ethnicity as well. It can be those who are intravenous drug users. So there are certain groups that are at higher risk of having HIV. But particularly when we talk about ethnicity and country of origin, etc., it's 2 things. One of the things is what I said about earlier, is that as Black communities, we're less likely to test, and that then results in having higher levels within our community. So we have higher levels there. Also, we also talk about country of origin, but also where you may be having sex. So you or your partner is having sex, because for many people, you may be living here, but your partner is someone that may be going back and forth to their home origin, etc. Or they've having regular sex there, and you see them, in, when you go to the other country. So you are asked certain questions because there are certain groups that are at higher risk. But I always say, anyone having unprotected sex is at risk of getting HIV, regardless of who you are, your color, your age, your gender. And being very honest, I am working to make sure that if someone goes for PrEP, they are asked minimal questions, and they are supported to have it without feeling that they're being targeted too much. But that's a personal wish for me, because I don't want anyone to. It can be hard to go and ask for it. So I want everyone to feel that if you feel it is something for you, don't be shy. Go and do that to protect yourself, because it's something for empowerment. Is the second one about the herpes and if the
about
male partner?
Herpes, so that the male partner is not wanting treatment, not accepting, and he's carrying on without using condoms. What do you do?
So it's really difficult. You know, when I have conversations with people about herpes and things like genital warts, which is caused by a virus as well, I say that, first of all, it is extremely common. And yeah, extremely common. And most of the stigma that we have is because the herpes, it can be painful. For genital warts, it's lumps and bumps, so it doesn't look very nice. So all of those feed into our concerns about it. But in a relationship, when someone has an infection and someone does not have an infection, part of that being in an optimal sexual health and in an optimal sexual relationship is that you both go into things with your eyes open and you make that choice together. So if he does not want to wear a condom and you feel comfortable with that, knowing that he may or may not pass on the herpes, because he may have sex with you all the time and for some reason you don't acquire herpes. But if you've both made a decision that even if you do get it, you know that it's common, it's manageable, it's not going to dictate your life, and you're comfortable with that, that is entirely your choice. And there are many, many couples like that. But if you feel that it is not your choice and you do not feel safe, or you do not feel that you are given the voice in that, then I feel that is a problem. And it's something that needs to be explored further. And you know, it's difficult to do that now, but I know in CAHN and other organizations in the call, you can speak to them to talk about having that support, to have those difficult conversations to get the support that you need. Because decisions about sex are fine as a couple. You have to make it with both of you feeling assured that you are happy to make that choice together. If there is a power differential, then something needs to change.
And on that note, I just want to say a massive, massive thank you to you, Dr. Vanessa Apea. Mm-hmm. It's been really great, very educative, very insightful. We've had lots of questions. I'm hoping we've managed to tackle all the questions in the chat box, but if we haven't, I do apologize. And please do send your questions to the CAHN email, health@cahn.org.uk, and do keep your sort of comments as well coming and send them to send those to them as well. We're grateful for everyone who's made it today. What a wonderful way to end the Women's Week, and so much that we've learned. I'll pass on to Elizabeth, I think it is, or whoever is going to take over from now. Thank you.
Thank you.
Thank you so much for that, Dr. Diana Santi, and thank you as well, Dr. Vanessa, for today's session. I believe it was very insightful, very informative, and you know, we can see the different questions people are posting on Facebook, on YouTube, and on Zoom as well. So thank you for the both of you, and thank you, Dr. Diana, for hosting today's session. We want to thank those as well that are joined in on Facebook, on YouTube, on Zoom. Thank you so much for week after week for continuously joining on our CATHIP Health Hour, for engaging, for sending in your questions, for interacting. We thank all of you that are joined in as well. This session has been recorded and has been streamed to our Facebook and YouTube channels. So if by any chance within the week you'd like to go back and watch again, always feel free to go to the CAHN YouTube channel or the Facebook page as well to watch back, and also share with your family, friends, colleagues as well. If you have any further questions, like Dr. Diana said, feel free to email health@cahn.org.uk. I believe our colleagues will still answer those questions within the week. And if you would like a copy of today's slides that Dr. Vanessa shared, feel free to email health@cahn.org.uk as well. Thank you once again for that. If you would like, if within the week you have any questions, any further questions, need support from our counsellors, always feel free. Our helpline, I believe my colleagues have posted the flyer in the chat box, and have sent in the contact details. So always feel free. Our counsellors are there, are accessible throughout the week, and we're here to support in any way that you need support. Throughout the week as well, I believe next week we're back again, next week Saturday, same time, same place, same Zoom details. and will also be streamed to Facebook and YouTube. And it is again at 11 o'clock till 12:15. And next week's topic is we are focusing on what are the reasons for pelvic pain in women, and the session will look at the causes, the symptoms, and the management of pelvic pain. We'll also be have some time to discuss how to manage your pelvic floor as women, and further into the topics as well. We'll also be looking back at what Dr. Eddie focused on last week on endometriosis, chronic pelvic inflammatory disease, fibroids, and pelvic congestion syndrome. Again, it is the same link, so always feel free to share those links with your family and friends, and join in, and let's engage and interact with one another. Dr. Diana and Dr. Asante also mentioned about, having that healthy lifestyle, making sure we're eating right, we're drinking right, we're exercising as well. So throughout on Tuesday, every Tuesday here at CAHN, we have our Healthy Hearts, and that is in the evening from 5:30 till 7:30. And the first half, we still are having our 24-week challenge on tailored support, with the group. So we're just focusing again on our diets, focusing again on our nutrition, making sure we're eating right, eating correctly, drinking the relevant correct stuff, and if there's still time to join in, if you would like to join a part of that, just simply email events@cahn.org.uk, and I believe we can register you onto the call. And we also have a physical activity session for 30 minutes. We've been having boxercise, so if you're interested in that as well, feel free to join on, and we can register you onto that call. If you have any other questions, like my colleagues have already mentioned, feel free to keep sending those in, and we will answer those as much as we can. And we're here to support you throughout the week. But yes, we'd love to see you all in our upcoming events, and feel free to register for those upcoming events coming in. Have a lovely weekend, stay blessed, stay safe, and we'll see you back again on our Tuesday and Saturday. Have a lovely weekend. Bye for now.
Bye. Thanks, Elizabeth. Bye, everyone.
Bye, everyone. Take care.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.